Okay, good morning, everybody. First of all, my most thanks for inviting me to be here again. It's my pleasure. I'm so glad that I can come back to Singapore again after last 4 years. And this is a really wonderful auditorium. This is so nice. Okay, the topic that I was assigned is a little bit difficult. I'll talk about the Falco-Tentorial Dural Arterio-Venous Fistula by means of endovascular management. And actually, this is our team, and all of this work will contribute from our team. Beforehand, so I must briefly review about the anatomy. As you know, that the Falco-Tentorial area, so it is at a junction, between the fourth cerebri and tentorial cerebelli. So roughly we can divide it into three areas, right? The midline location. It usually receives, drainage from the tocular or tentorial cerebelli, and on the lateral is the fixed point of the tentorial cerebelli to the pedis area. So if the shunt occurs around here, we call it is in the lateral location, and the other is the free edge of the tentorial, the free edge of the tentorium. Okay. And a little bit about the dura that you already know, that actually the dura, we can separate it into two layers. This is something a little bit different, from the skull outside and the dura that lie along the skull. We call it periosteal, or in some papers they call it just periosteal dura. And then the dura that's on the intracranial surface, or is along the pier, or the pier matter. So this is we call it the dura propria. And for the vein, from the inside the intracranial bridging vein, as you know, that is across the sublignoid space, and some of them, they can drain into the leptomeningeal epidural vein or chest epidural vein, and then to the diploic vein. So according to this, and most important is that it's a little bit different of the origin between the dura propria and ostial dura. Okay, sorry. The dura propria. Dura propria is inner, right? So it's inner, and by embryo, it's derived from the neural crest, whereas the ostial dura is derived from the mesoderm, is the outside. And you can notice that it is only the fourth cerebelli and the inferior sagittal sinus and around the tentorial cerebelli that is covered only the dura propria. So what does this mean? So it means that when there is the shunt that occur around this area, so it's easy that it can reflux into the leptomeningeal veins. So as you know that in this area it's almost always aggressive. This is a contrast to the shunt that occur in just like the so-called osteodural, or the shunt that is around superior sagittal sinus or common sinus, that is occur just close to the ostial dura, right? So normally it will not have the cortical reflux until there is the occlusion of the draining vein, right? Obstruction, so it just retrograde into the cortical reflux. So it's roughly, this is a natural history of that. So this is corresponding to the paper that you already know, that right? That by embryo, we can differentiate from the shunt, that's called the epidural shunt in three locations, right? I will not go deeply into it. And around this area, that that is called lateral epidural shunt or leptomeningeal epidural. This is the green area. So this is, as you know, that it's occur, right? Because it's close to the dura propria. So in this area, it's always that present with the cortical reflux, and in the literature they say this is the male predominant. So in our group, Falco-Tentorial is also in this location also. That is the lateral epidural. This is opposite to the things that is occur here or in the dorsal epidural location. That it is close to the osteodural. So in this area, normally that it will not has the cortical reflux until there is an obstruction or thrombosis of the dural sinus, because in this area they usually drain into the sinus, but once there is obstruction or thrombosis, then it's a cortical reflux. So natural history is different. So again, for the especially in this area of Falco-Tentorial area, we can differentiate into three groups, right? Lateral group, lateral group usually receive supply, drainage from the lateral and inferior surface of the temporal lobe and the occipital lobe. Okay, so it's around here. And in the medial group, okay, maybe usually occur around the straight sinus or torcular or something at the vein of Galen. And definitely it will have the reflux into the vein of Galen, into the deep vein, and also reflux in the infratentorial venous drainage. And the things that can occur is around the free edge. So in here, the vein reflux into the basilar or lateral mesencephalic vein or even spinal vein. This is some example that it is a lateral tentorial location is here. You can see that it can, this is AP view, so it can reflux into the straight sinus vein of Galen, and finally, it's, most of the things are supratentorial venous congestion. And here, if you look carefully, it is the shunt in this area, that is shunt at the free edge of the tentorium. Okay, this is supply from the pituitary branch of the MMA, that's right here, and drain into the pontomesencephalic vein, and finally into the vein of Galen and straight sinus. And middle location, it is the, I think this is the most common of this area. Okay, it can occur at, as I mentioned before, around the straight sinus, torcular, or even just close to the vein of Galen in this area. And thank you, Professor, to talk about the artery of Davidoff and Schichter. Why I have to mention this? As you know that normally dural shunts that always have the supply from all the meningeal branch around that area. So in the Falco-Tentorial location, the meningeal arteries that usually supply from the middle meningeal artery, sometimes associated meningeal artery, meningohypophyseal trunk, and posterior meningeal artery or artery of Fox cerebelli. But one of interesting, I was speaking the truth that in the past, I don't know this artery before. They say that this artery, it is the branch usually arising from the P2 of the PCA. Sometimes it can arise at the P1-2 junction, and it cause it's surrounding the brainstem beneath the free edge of the tentorium until it reaches at the junction, and then it can go up into along the leaf of the fox cerebri. And in many papers say that normally we cannot recognize this artery until there is something just like a tumor that occur from neural crest, remember, or even from the shunt. And this is what they say. The important is that if you can recognize this artery, they say that this artery is the purely meningeal vessel. So that this means you can go in and embolize it without afraid of anything, just accept that it will reflux into the other branch of the PCA. But I never do with this artery. Okay, and this is from Michael Sudamong lecture. Okay, this is to see the course of the artery of Davidoff and Schichter. Okay, in lateral and AP view, and also in this paper. You can see that is along the course in AP view and in lateral view. That's around the brainstem and to the edge, and then it can go along the leaf of Fox cerebri, and finally supply the dural shunt at the suprasagittal sinus. Okay, so we come back to our Falco-Tentorial location. This is all the example. I will say that it's not what. Okay, so sorry. Okay, so it's good to stop something that you can think. So the next is all are the example of the case. So the first case, please notice that this is female. Actually, in many papers they say that it's predominant in male. These ladies come in because of acute hemorrhage at the cerebellum right here, and all the angiogram. Okay, you can see that there is the branch right from the occipital artery and go to this area. It is the proximal of the straight sinus here and reflux into the straight sinus and vein of Galen like this, and with the significant cortical reflux. And most all the time they can supply from both sides with a similar venous drainage like this. And also from the vertebral artery that you can see here, that is supplied from the artery of the fox ability to go to the same area with the congestion of the posterior fossa. Okay, and because of this, we can approach. So our goal, most of the time, we will go no matter what, this or any dural shunt. So if we can go via the transvenous, we almost always sacrifice the sinus. So we go to this place and to see that definitely it's at the same point, and this is the point where it is stenosis or very serious stenosis. After we success to go there and we just put the coil, we still use the fiber coil. After packing the coil, you can see that all the shunts are gone and everything's are okay. And almost all in the case the straight sinus and the vein of Galen will not get back, but the brain can empty like this on the right side, on the left side, even from the vertebral artery. The next case, female again, and this patient, interestingly, came in because of tinnitus, nor any neurological deficit. And you can see here that the shunt from the MMA and to the a little bit distal of the straight sinus here, and it can integrate drainage into the transverse sinus and can empty out. So this is the reason that the patient don't have significant of neurological deficit. But please notice that there is another shunt, okay, that from the STA and passing the osseous branch here and shunt into the epidural, okay, into the epidural vein, and finally reflux into the cortical vein also. So we try to manage by both shunts in the same time. This is the same location. This is also supplied from the dural branch from the pituitary of the anterior cerebral artery also. And you can see that there's significant of dilatation or congestion of the brain without any visible of the straight sinus right here. And you know, interesting, the patient don't have any symptom. And also here, again, that supply with artery of fox cerebelli here. And if I understand well, you know, this is the retrospective. Maybe this is the artery of Davidoff and Schroeder, as I mentioned before. And you can see that there is no occlusion distally along the transverse sinus. Okay, so we manage both shunts in the same time. So it's easy to go with the first one first. This is glue. In the past, it is almost our favorite using glue. And after that, we go to this one. And you can see that from the vein of Galen, they also reflux into the cortical vein also. So it don't difficult to go via here and until we got into the vein of Galen and put a coil. And this is immediate. After that, you can see that even we did the brain does not use the deep venous drainage, but the congestion is significantly improved with the result of these things. The next case, 50 years old man came in with the cerebral hemorrhage and obstructive hydrocephalus because of mass effect from the hemorrhage. Sorry, I didn't bring the CT scan. And you can see that the angiogram, that actually is similar pattern that almost always, I mean, in the midline location, it almost always supply from bilateral of external MMA, occipital artery, and also with the posterior spinal and artery of Fox-Sebeli, and sometimes with the artery of the Davidoff, as I mentioned before. And similar to this one, this is from the occipital artery supply. And you can see that the shunt, it's at just the, I think this is the junction of the trochlear and the straight sinus, and with the reflux. Okay, and on the left side, similar pattern to go to, even though different lesion, I mean different point of the shunt around this area, but it's the same of venous drainage. Okay, from this one artery of Fox-Sebeli go to there. Okay, with a venous congestion, and interestingly, this is another branch, right? Artery of Fox-Sebeli, just quite large and direct to here, okay? And because this is large enough, so our staff, okay, try to go there. And you can notice that this is the microcatheter that we can use, and here passing this curve and get into that point. And after we test injection, we found that it is the same, similar the same. So we used, if I remember, it is the onyx. The reason why we don't use coil, because we consider that because of, you can see that according to this artery, it, when you use the microcatheter using for coil, it should be a little bit larger than this one. And we thought it impossible to go there, and the other arteries are small also. So we decided to go with the smaller microcatheter and to there, and I used, the DMSO base, no matter what anything, but this may be onyx, okay? And this is the onyx cast inside there. So with the goal to complete occlude of that venous pouch, and this is the outcome. You can see that it here, and we do the 3D to see the relationship between the onyx cast and the vessel. Okay, quite good result, and improvement of the venous congestion. Normally in this kind of patient, we bring the patient back maybe 3 months or 6 months to see again. You can see that there is some change of the vein, and sometimes you may see another shunt again. Okay, female again, 60 years old. 60 years old came in, because of progressive dementia. Right, something like this, and when you see the calcification like this, you already know that this is very long process, right? So the patient should have chronic venous hypertension for many years, and this time the patient came in because of significant confusion and convulsion. And from the angiogram, you can see that, okay, you're not surprised, right? The shunt is just close to around the trochlear area, and reflux into the superior sagittal sinus, and with significant congestion like this that can explain about the appearance of the calcification, okay, from every vessel, including, okay, C5 branch or hypocele trunk, like this, with significant congestion from the other side. And the reason, you may know that the reason that is significant congestion because it thromboses, bilateral complete thrombosis of the sigma in sinus there. Okay, so all the shunt, or all the venous drainage just go back into superior sagittal sinus and congestion, as you can see. And because of it thrombosed bilateral, sigmoid sinus, so we don't have chance to go with the transvenous access, right? And finally, we choose this one. This is the MMA. And normally, we choose the vessel that with that not significant torsion RCT, and then we can control. Okay, this is the right MMA, significant congestion also, and here, right, similar pattern, and then you can predict all the artery supply. So the first time we go with the right MMA, and this is what the first time. Actually, it is the same setting. You can see that the onyx cast didn't pass into the venous space that we expect. Okay, then we go. This is point at the microcatheter to another, to the other side, and finally, you can see that we got the cast completely in the sinus that we want, and this is the outcome. Okay, although there is this congestion, but the patient improved like this, and congestion is improved. This is male came in because of alteration of consciousness and weakness. Okay, and when you see this, you may know that, and you can make diagnosis of the thrombosis, right? Venous thrombosis of the bilateral thalamus here. And interestingly, the patient has history of crippling anterior-communicating aneurysm last 7 years. And here you can see that the shunt supply, this is from the right occipital artery, right, to the distal straight sinus. Okay, actually it's a mid straight sinus, because the proximal one, this is already thrombosed, and this causes the significant reflux that you can expect, right? Although you can see that from the supratentorial, it's not significant congestion, and the brain didn't use the deep vein, okay, but some stagnate at the temporal lobe here. Supply from the posterior fossa artery, they're still the same. Okay, so our strategy is that we try first to pass this stenosis, and finally we success to go there. And our strategy is that we try to sacrifice all of this. Okay, after test here, and this is the coil that we put, and it's here, you know, and in the same setting. Okay, and you can notice that the vein of Galen, okay, this is a vein and vein of Galen that it come back again, okay, come back again, but you didn't see the straight sinus. And that night, the patient have a little bit intraventricular hemorrhage, but the patient resolved quite well after everything is gone. Male again, this patient presented with the headache and meningism. As I review his history, he was treated in the other private hospital with the meningitis, fever with meningitis, and then MR just revealed that there is some hemorrhage at the thalamus, and look like see a little bit of dilatation of those veins. So the patient was sent to us. We do the angiogram, and okay, again you can see that the supply. The shunt it's close to the vein of Galen, drain into the straight sinus and go to go to the transverse sinus. Okay, here. I think there should be some artery of Davidoff. It's just there, no? Okay, like this. And on the other side also similar thing. It's also similar. And we try at that time. I think this is a long time ago. Go with the strategy to sacrifice. This is with coil, but maybe it's not that good. You can see that the coil just reflux down. Actually, we need it should close to this area at the shunt. And during test injection, you can see that we cannot obliterate the shunt. And please notice here, the meningeal arteries come here with reconstitutive of vessels of supply back into this again and drain. So what we do? And this is also, right, from the axonopharyngeal artery direct to this. So what we do is that we bring the microcatheter a little bit down, no, not down, just go inside the coil mesh and inject onyx inside. And this is what happened. This is already here. Okay, this is very interesting. This is very interesting. 66-year-old female came in with, everybody can diagnosis of dural CCF, right? Definitely, it is dural CCF. But if you notice, okay, on the more early, as you can see the supraophthalmic vein, you can see that there is abnormal vein at the fossa here that resulting from the shunt of piso-squamosal branch. The shunt is right here. And also, you can notice it from the posterior fossa, from the vertebral artery injection. I'm not quite sure that it's supplied from the ICA or from the other, but definitely, finally, the vein is still the same. So this is not difficult for us, right? We go through the squamosal branch of the peninsular artery here, and still keep in mind that this is the one of dangerous is that the facial arcade there. But actually, then we inject and it looks like this, and we heal it. If I remember well, my staff do this with glue, and it's still okay. So that's just interesting to demonstrate that Falco-Tentorial shunt can occur with the associated with the other shunt also. This case, the patient came in because of right side numbness and dysarthria, and on CT MR demonstrate that there is a partial thrombus of the VA and pica junction aneurysm. It doesn't matter for this, and but during running angiogram, okay, we just recognize that there is a tiny shunt here from the axonopharyngeal artery, right? Just go to here, and it's draining along the pontomesencephalic vein, right? Pontomesencephalic and posterior mesencephalic, and drain like this. So this is, we call that it should be the shunt along the free margin of the edge, right? So the patient already creep, unusual creeping and bypass surgery, and then we bring the patient back. You can see that this shunt look more pronounced than before. And because the artery is so tiny, and our staff try to go there, trans artery, but it's impossible. Okay, also from here, you can see the shunt also. And so he go with transvenous carefully. You can see that this is the guiding catheter, right, from the right transverse sinus into here, and go along with the microcatheter until to the same point where the shunt is and this test, and slowly inject onyx without difficulty, and you get this result. All the things are disappear. I think this is maybe the last case now. This case actually, a 26 years old male came in with the clinical look like CCF, but the patient has complained about proptosis, no chemosis, no tinnitus. And on the MRI, just demonstrate that, okay, significant dilatation of the supraophthalmic vein, but a lot of, dilate of veins, right? We bring the patient forward doing the angiogram, and you can see that there is the shunt at about the torcular and the sinus junction, and with reflux, okay? And again, it's an occlusion of the transverse sinus here. Okay, so it's like this from supply from bilaterally, and supply. This is from the occipital. Definitely in this kind of case, so we choose transarterial access first. Okay, as you can, and this the things that we can explain that why the patient have proptosis, because the brain, the normal brain, used, okay, is getting back into the SMCV, and use the ophthalmic vein to drain normal brain out of the skull. So that's the reason that the patient don't have any neurological symptom, even though the patient has bilateral thrombosis of transverse sinus, okay? And see, just look ugly, the rotation of the vein like this. Okay, so we go, okay, trans artery to here. Okay, and injection, this is from the first time, I mean, the single injection of the onyx until we get this point. And we bring the patient back in 3 months because we're not sure. And you can notice that there is residual in the pouch that the onyx didn't fill with some residue of reflux also. And 6 months, you can see it, you know, more intense. So which vessel we're gonna use, okay? And this is also from the hospital also, right? So we think that this one may be easier as compared to that of the ocular artery because of the tortuosity. So we choose the minuscule branch of the vertebral artery. And finally, we success with the microcatheter to go there. And when we reach this point, it's not difficult, right, to slowly inject onyx and compare to the onyx cast before you get the new onyx cast here. So it means that all occupy in the pouch. So we will call this successfully the patient healed. Okay, so lastly, my take home message is that Falco-Tentorial shunts are infrequent, however, and almost nearly every paper say that always aggressive, right? Remember from the very first pass of my talk, that because of nature. So it's mean of it close contact with the dural, so it have direct cortical venous reflux. And according to that 3 location, medial location, tortuous, sinus, or even vein of Galen is the most finding. And particularly in our experience, we have 2 cases that found in the association with the multiple dural AVF, okay, and we also found the female group, but I may apologize that I didn't review this all and didn't have the report of series. Anyway, endovascular treatment will be successful with the goal to complete occlusion of the diseased sinus, or at least, and also include the foot of the draining vein. So the choice can be transarterial or transvenous. It depends on the anatomical disposition in each patient that I demonstrate before. Okay, but once it failed to access that route, lateral surgery is also a benefit. I didn't bring the case to demonstrate, but on review, I think I found about 3 cases in the past. In the past, we didn't use the MSO base, we used screw, and we found that we cannot go more. And we send those patients for lateral surgery, and the patients is healed. Okay, thank you very much.